This is Dr. Gartzliz, and this is the ECG Diagnosis of Cardiac Ischemia. Okay, so let's take a quick look at the anatomy of the coronary arteries. First of all, the right coronary artery starts in the aorta, travels down the sulcus, and splits into the right marginal artery, and then behind the heart with the posterior descending artery. The left coronary artery arises from the aorta and comes across the front of the heart as the left anterior descending and sends a branch, the left circumflex artery, to the posterior aspect of the heart. So if we draw out the direction of the leads, first the inferior leads and then the two lateral leads, then as you remember, the V leads come towards the chest wall. So if we consider an obstruction of the left anterior descending, which would be occurring approximately here, and would affect the anterior aspect of the heart and therefore change the anterior leads. These anterior MIs can be the most devastating because they affect the left ventricle and a large proportion of the heart. Obstruction of the right coronary artery will affect the inferior aspect of the heart 80% of the time and also affects the right side of the heart. The other 20% of the time that the inferior leads are affected, it's because of obstruction of the circumflex artery, which also supplies the posterior aspect and will give posterior lead changes. Obstruction of the septal branch from the left anterior descending will give septal lead changes in V1. Obstruction of the circumflex artery can also give changes in the lateral leads, which are lead 1 and V6. Since there's no leads over the posterior aspect of the heart, posterior MIs show up on the opposite side leads with ST depressions in V3 and 4. These are depressions because leads V3 and V4 point out the front of the heart and the posterior MI is at the back of the heart, and therefore a mirror image. So in order to understand ST segment changes, we have to understand what's happening in the coronary arteries. In a regular coronary artery, the plaque is stable and there is no thrombus, so that means that there is stable but less blood flow. Acute changes can occur so that the thrombus forms and partially occludes the coronary artery, which can then give changes in the ST and T waves. The T waves can be inverted and the ST segment can be depressed. If the coronary artery is acutely and completely occluded, then there is transmural ischemia, which causes an ST segment elevation. For the ST segment to be qualified as elevated, the ST segment has to be over 2 millimeters in leads V2 and V3 for males over 40 years old, and 1 millimeter in all other leads. For women, the ST segment has to be elevated more than 1.5 millimeters in V2 and V3 and more than 1 millimeter in all the other leads. As we already discussed, the patterns of the lead changes tells us about the anatomical location of the ischemia, with lead V1 and V2 indicating septal ischemia, lead V3 and V4 indicating anterior wall ischemia, lead V5 and V6, and lead 1 indicating lateral ischemia, lead 2, 3, and ABF indicating inferior ischemia, and posterior ischemia is a downgoing ST segment in V1 to V4. So let's diagnose this particular ECG. We'll have a closer look at the V leads, and we can see that there is elevation in V2, V3, and V4. And if we take a ruler, we can measure from the baseline, and we'll do that in V2 and V3, and then we'll have a closer look at the elevation. And when we look closer, we can see that it is greater than 2.5 small squares, and we see that rise there and there. So when we see these ST segment changes in more than one contiguous lead, then we can make a diagnosis of acute ST elevated MI. And with leads V2, V3, and V4 elevated, it is diagnosed as an anterior septal ST elevated myocardial infarction. Now here is what T-wave inversion would look like, and we can see that the T-waves in the septal leads are inverted, which is showing some septal ischemia. So with the proper biochemical evidence, we could diagnose this as a non-ST elevated myocardial infarction.